Howdy, folks.
Howdy.
Welcome to the show. Welcome to the Harm Reduction Report.
It is the Harm Reduction Report. It is December 4th, a very snowy morning.
Yeah, snow day today.
Cal, you had class today, didn't you?
Nope.
It was canceled?
It was canceled, yep.
Wow. How did you make it all the way to my parents' house from downtown?
Oh, luckily I have a all-wheel drive vehicle, so I was trudging through the snow in my army tank of a car, army tank of a truck. I was able to make it through the slippery slopes, the ups and downs here in Grand Forks. But I did see several cars, pulled over on the side of the road and needed help, and I'll have to get out there and help them on the way home.
On the way home, when they've frozen for a few hours.
Yeah. I'm sure there'll be more.
That's a good strategy. Well, it's another episode of the Harm Reduction Report. What is the Harm Reduction Report, Cal?
Yeah, so welcome to the Harm Reduction Report, where we're going to get down to the nitty-gritty about drug-related topics and, different harm reduction material, how to mitigate the risks involved in drug use, and discussions of sensible drug policy that can help society in general. So we have a lot of different directions we can go. In this episode,
we're going to hear Frank.
We're going to hear Frank. Yeah, we're going to hear from our advisor, Frank, and he was talking at an event called Thirsty for Justice Thursdays, hosted by Kylie Oversen. So we'll get into the recording and then do a little discussion afterwards.
This is your friend Willard T. Belly with your pal Cal. Kylie Oversen hosts this Thirsty for Justice Thursday seminars at the Christus Rex Center on campus. And last week they did a talk. The theme was about addiction. So they had Frank. Frank was there. Frank White, the advisor of the UND Students for Sensible Drug Policy and Psychedelic Club chapter. Frank was speaking about addiction, as well as Michael Dulitz, who was just newly hired by the city of Grand Forks Public Health to as the Opiate Response Project Coordinator. So they're doing things like hosting events and talking about what to do about it. What to do about it.
Well, thank you for joining us tonight. I expect usually a couple people are running late when they come to these events, but I've actually grown to like the smaller groups that we've had because it really allows us to have a good informal conversation about the events that we're discussing. And as Chad said, this series has been happening over the past year. Jane, I think you've been at almost every one. So thank you.
So good.
And so we've discussed everything from healthcare and immigration to criminal justice reform and gender equality, domestic violence, and tonight we're really excited to have Michael and Frank join us to talk about addiction. So this will be, I will have a few questions after we do introductions, but then we're just going to open it up to have some conversation. Knowing Will and Nate as I do, I know these are issues that you've been working on and are passionate about in our community, so I'm glad that you're here to participate as well. So to my right, Michael Dulitz.
Dulitz, yeah.
Dulitz is from the Grand Forks Public Health Department. He is the Opiate Response Project Coordinator. Just started earlier this month.
Yep.
He
Masters in Public Health.
Yes, yep, which we're excited about.
Yep.
He previously worked at Essentia Health in Fargo and also worked as a paramedic for 6 years. As Jane said, he has his MPH from here at UND in Health Management and Policy and also has a bachelor's in Sociology from Augustana College. Michael is passionate about identifying and addressing social and health gaps, and in his spare time, he's an avid traveler. Michael resides in Fargo right now with his wife, Laura, and their dog, Millie. So thank you, Michael, for joining us. And Frank White, to my left, has been the last 30 years as a sociology professor at the University of North Dakota. Originally from Walhalla, he started his teaching career in 1982 at Lake Region Community College and was hired by UND in 1988. Frank currently teaches Introduction to Sociology, Social Problems, Drugs and Society, and Sociology of Sports. Frank was also a visiting professor at the American College of Norway and serves on their advisory council. He also sits on the board of directors of the Pembina Gorge Foundation and hosts the Frank White Golf Tournament and Scholarship Fundraiser held annually at the Walhalla Country Club. Through the years, White has earned numerous awards, including the UND Foundation Award for Professor of the Year, the UND Foundation Award for Academic Advisor of the Year, the Faculty Service Learning Award for Community Engagement, and the North Dakota Spirit Faculty Achievement Award. So thank you both. Thank you, Frank and Michael, for joining us. And then I'm going to give each of you just a few minutes to talk a little bit about how you got into the work that you're doing as it relates to addiction and drug use and culture. And then we'll go from there. So, Michael, if you want to start.
So getting into this, I started in healthcare when I was in high school, first as an EMT in my hometown, and then I became a paramedic shortly after while I was working on my undergrad degree. And over time, addiction's always been something that's been talked about, and I see it through two different lenses: the lens of the healthcare system, which is very negative about it, and the lens of the, on the more academic side, which has a lot different opinion of addiction, and it's been something that's always been kind of in conflict in my head, because I see addiction on a day-to-day basis, working in healthcare, and then I have my my beliefs formed in the academic realm. So what really got me started on the opiate spectrum, or working with opiates, is I did a project for my environmental health class a couple of years ago where I started looking at opiates because I was realizing that it's becoming a problem. People pushing people out of cars in front of hospitals that had experienced opioid overdoses, and we'd go out and save them, and they would go drive away, and that's pretty scary. So I did a project where I was looking at opiates, and I immersed myself in the world of opiate use for a couple of weeks, and I found wonderful online communities where people were very frank about their opiate use, and I realized that it's a lot of really good people that are struggling with an addiction, and that just kind of helped reframe things in my head, and and bring things from an academic realm into my work in healthcare. Since that project, my work's been evolving, but then recently I got the opportunity to work with Debbie Swanson. North Dakota received some federal money, which was granted to the 5 communities and 3 tribes in North Dakota. Grand Forks being one of those communities, $180,000 focused on opiates. We're working on building opiate infrastructure, treatment and prevention infrastructure. 20% of the money we received is catered towards prevention, and 80% towards treatment. And as far as evidence-based treatment that's most effective, Grand Forks has no providers that really provide evidence-based treatment with medication-assisted therapy and peer support, and a robust peer support infrastructure. So I saw an opportunity here, and a position opened at Grand Forks Public Health. And so I started on November 1st, but the month before that, I went back into immersing myself into the world of opiate use. And so I had my work during the day, and then at night I'm learning from another perspective. So it's been a very much an immersion over the past couple of months. So I hope I can share some of those thoughts.
Thank you. Frank?
As Kylie mentioned, it's my 30th year at UND, and before that time I taught at Lake Region Community College for 6 more years. So my 36th year, and my last year at the community college, I taught a class in social problems, and a whole unit was spent on drug education. Totally fascinated with it as well, back 36 years ago. And when you teach sociology, and certainly when I came to UND, I taught Introduction to Sociology, Social Problems, very broad-based stuff. I had one specific course called Sociology of Sport, but most of them were very general, statistics or methods. But when I came here, there was an opening in our department to teach drugs in society, and nobody wanted to do it. The guy had retired, and he was a tough guy to follow too, Dr. Richard Wilsnack and his wife. You probably know Sharon Wilsnack, and They Team Todd, they did everything in that area, PhDs out of Harvard, and not anybody want to follow that, but I was pretty excited about it at the time. And I thought this could be an area I could kind of specialize in. I saw a niche there. And for the next 30 straight years, I had no idea how much work that would be to keep current on the changing drug climate. And I wanted to keep current on the drugs that students in college were using in high school age too, because 90% of all the addictions, even today, 90% of prescription drug use starts in your teen years too. So I found that, I researched, I immersed myself, and I continually have spoken about it. And not that I'm an expert, but with a 30-year perspective, I've pretty much seen a lot of the major drugs, both legal and illegal, see them run their course too. I go back to the late 1980s with methamphetamine, that ice age they were talking about as that came across the state and peaked and subsided. The bath salts, the synthetic drugs in the 1990s. And then today, we're starting to see the opiate, the synthetic drugs that have superseded everything. There's more people dying from illicit painkillers, not illicit, but what we call offline, people getting diversionary tactics to use those drugs. And it's killing more people and young people than all the car accidents and all the other drugs combined, heroin and cocaine or whatever. So I made a point to go and speak to high schools over that 30 years on whatever the drug choice they asked me. And I pretty much let them decide. They got a pretty good feel on the pulse of what drugs they like to hear. And they asked me, could you come in and do this drug, this drug? And recently, the last couple of years, I'm getting requests to speak on opiates. Opioids, we'll talk about the two different, same term, but it is the drug of choice of the millennials, and all the problems associated with it, and whether it's law enforcement or education or parenting, there's a lot to know out there too. And I'll mention one other thing too. When you have these epidemics, in the beginning of the epidemic, like whether it be meth or be opiates, is that the use, is going to peak because a lot of the negative consequences aren't out there yet. People don't know enough about this. After it runs this peak, like we've seen with bath salts and meth, there's still problems, but they're not the same thing because we get education out there, we get some research, we get quality speakers, we get an organization like yourself and funding to go and get the community more aware of that too. So I'm seeing that right now with the opioids. We're at that peak. It's an epidemic. It's something we need to address, and I don't know if we're doing as much when it comes to the funding. You're talking about you might not be funded in April 15th. This, what it's doing to our young people, what it's doing to professionals. I don't know how they cannot get out of it. And in the beginning of an epidemic, that's where you want two things. You want drug awareness. You want to get more information out there. Whatever literature is there, what you're doing, what I'm doing, get that out there as soon as possible, and also work with the law enforcement. It's you're not going to rush yourself out of the problem. You're not going to educate yourself out of the problem, but you've got to get those working together and get the information out there to show the consequences and get ahead of the curve. And I'd like to think that I'm doing part of that with my class, with my high school visits, and with the students that go out and talk about that topic in their work and in their families.
Okay, thank you.
And you were in that class.
I was in that class.
Yeah.
So I'm going to ask you a follow-up question right away, Frank. When we're looking at what we would classify as an epidemic, there's been, maybe for the last 5 years in the media in North Dakota and across the country, a lot of conversation about this epidemic. But what I'm hearing you say is that maybe it's overblown. Is this a trend that we've seen before with other drugs, or is this something that's a step above the other epidemics we've seen?
No, I don't think it's overblown at all. If anything, I don't think we have enough of our resources and educators out there talking about it. I think it's kind of come upon us very quickly. If you look at the literature, we talk about heroin and fentanyl and all those illicit drugs out there, prescription but illicit as far as people using them. We're seeing now that people are getting started on prescription drugs, and that's leading them to street heroin. We've never seen it before, and it's relatively recent, it's relatively new, and the ante has went up quite a bit too because these are so powerful. And people don't realize too when we talk about the epidemic. When you think about the word epidemic and what it's used, epidemic basically means epi means upon or around. Endemic is the people. And what you're seeing is that the epidemic is really around a specific population of younger people that aren't very knowledgeable, people that think that they're invulnerable. And this generation has the option of the internet that a previous 1 or 20 years ago we didn't have that. We didn't even talk about this 15 years ago. that they have now, and the dark web that maybe parents don't know what a lot of kids are talking about with that as well too. So when I look at that epidemic, I see it as a key concern, and I don't know if we're getting the information out there as much as we should, because you got a drug, and what's kind of thing about drug, and you'll hear about this, when you see people die from these drugs, or the addiction or the treatment or whatever, if you get street drugs, from the internet, if you get something that's low purity, that can kill you too, just because it's not what you thought you were taking. And if you get stuff that's high purity, that can kill you as well too. We've never seen drugs that could do that before. And then now people are starting to dab, some of the stuff with fentanyl that has 100 times the potency of a lot of the most powerful prescription drugs too. That's a dangerous game of Russian roulette, and students don't know it. So you can guarantee that a lot of parents don't know that. And I just spoke to several high schools on this very issue for this last 5-week period. I asked every one of the students, these are seniors now, have anyone ever had a drug education class in college, in high school yet? Not one. Nobody's talked to you about the DARE project in grade school, And I'm thinking that because of budget shortcuts, because of the emphasis on that too, I think that's one of the things that gets cut is education awareness. And I think it's, when you talk about justice, I think it's criminal that you have an epidemic like of this with high school and the internet options, and there's not someone speaking out there. The law enforcement is more involved in this too, and we're not seeing more of this on television as well. I'm just surprised by the nonchalance. So I think it's the opposite. I think we're as a society, underestimating that and its impact.
Right. I guess for context, when I was in the legislature, I served on the Human Services Committee, so we addressed addiction and mental health and behavioral health services in the state of North Dakota. So from the perspective of available services in the state, I understand how woefully unprepared we are and how underserviced we are across the state, especially in rural areas.
Yeah, you're right, especially in rural areas. If you look at the war on drugs too, you look at that $25 billion budget every year, most of it goes to law enforcement, and the rest of us fight for the education or the awareness, and harm reduction, which is another option, zero. We don't have a drug czar anymore, and Donald Trump's going to appoint one soon, but the person he wanted dropped out. But I think it's way underplayed here too, and national, and the needs at the rural and the college.
Sure.
It's the same.
Michael, you were talking about immersing yourself into opiate use in the community. Tell us more about what that means and what you were doing.
So, when you think about immersing yourself, you really want to know what path someone really took to start using opiates. You want to know how they're going about their opiate use, sourcing, how they are using. There's a whole variety of ways that people use, and they start at one. They start with things like pills, and or either legitimately prescribed or diverted pills, and then they moved on this continuum as the opiate starts to, or as the addiction becomes stronger and stronger, and then they move on to snorting, which people feel okay with it. Okay, I'm gonna snort, and this isn't bad. And I got this under control, and then they move down to they'll move into the world of what they call plugging. Which is taking drugs through the rear end, because that bypasses your liver, and then, eventually in that realm they'll end up moving towards things like heroin as the cost of prescription drugs diverted, or legitimate, as that supply either gets too expensive or or unavailable, then they move into the world of heroin, and so. I spend a lot of time on basically the opiate board on Reddit. I don't know if there's any Redditors in here or not. And there's this isolation that people talked about when they are addicted to opiates or have opiate use disorder. There's this isolation from people that they know, and so really this underground community develops, and that's what people really lean upon, and so that's where a lot of these harm reduction initiatives and stuff have started. Are people that are concerned about about each other, and you talk to someone that's using or that has like an opiate use disorder where the addiction has become a significant part of their life, and they tell people who are starting to use or are casually using, they tell them to stop. They don't want people to go through what they're going through. Another thing that's really that I've gleaned from this is that it kind of becomes once the addiction is taken over, you're using opiates to not go into withdrawal. So that's the difference with opiates, is that the withdrawal symptoms are so intense. They won't kill you, but they're very intense, and so you're basically going from day to day avoiding withdrawal versus getting a high or a rush or anything like that. So your mind it's sometimes taken akin to like a hunger or thirst. So you're just working to get that next amount of your opioid, so you don't feel like so you aren't in withdrawal. So when you think about what people do to basically to score to get their opiates, they're basically trying to meet their needs in whatever way possible, because they feel just like a hunger or thirst. It's when you're hungry, thirsty, you do things that you wouldn't normally do, and it's just along those lines. So really understanding that whole continuum is what I mean with immersing myself in that world. So.
If I could add to that too,
Yeah.
because you're absolutely right on spot on there too. With the opiates, which is different from a lot of other addictions as well too, is that they call that the yin and yang approach, where people ask, how can those people possibly be hooked on heroin? Why wouldn't they just stop that? Well, one, there's that psychological addiction too, that good feeling. But after you do it for a while, you talk about addiction, if you use it for a long period of time, is that you don't get the high more because you built up a tolerance for it. Mm-hmm. And most people at the end of their careers or in the height of that drug career is that they're taking the drug not to get high anymore or to feel good. It's to prevent that withdrawal or that getting sick, what they call being dope sick.
Yep.
And when it comes to opiates or painkillers, the lady speaking of that class, she doesn't like the word painkiller because you never kill the pain, but pain relievers. When you take those, the withdrawal from painkillers or opiates is much more physical than it is the other drugs like LSD or PCP, which is more psychological or hallucinogenic. Mm-hmm. And I'm told by people that went through that withdrawal process and with the medical health community is that that is a pain almost worse than death. They'll do almost anything to prevent that withdrawal when it comes to taking heroin or fentanyl or methadone or whatever the case happens to be.
And that's why people end up, or that's one of the things that contributes to overdose, is that you become so physically sick of the cycle that you start to use more in hopes that maybe you won't wake up, because it's just taken over your life that much. The other thing is with your traditional addiction type treatment programs is they're many of them are oriented towards abstinence. So you drink a lot, or you have an alcohol use disorder or alcoholism, you quit drinking, we help you quit drinking, we help you through the withdrawal, and then we help you beyond that, and you can eventually get back to a relatively normal state. With opiates, abstinence-based therapy or abstinence-based treatment programs only have about a 10% chance of succeeding, because it changes the chemistry of your brain, essentially. Your mu receptors, which are your what the opiates act upon. You have so many of them that you can never satisfy those receptors with what they call the endogenous opioids, the opioids that are already within your body. So you're constantly craving, and so a lot of people end up leaving and using right away, and then when you lose your tolerance, and then they use their normal amount. And so one of the times that a person's most likely to overdose is after they've left an abstinence-based therapy program or jail.
So tell us more about what you are doing with this project with Grand Forks Public Health, and is this a new program altogether, or is it focus shifting?
So with our program, we have created, part of this program. It's informed by the mayor's call to action. the mayor's call to action steering committee is the oversight for this grant, and so they identified through their committee work different areas to focus on, and so I'm using that as kind of a template, as well as the state wants to see evidence-based interventions, and the point with the 2080 or 80/20 is to really develop a robust treatment infrastructure in Grand Forks. So you're going to see, in the coming, months, you're going to see a lot of talk about prevention, and you're going to see us going out into the community and, equipping people with Narcan, and training them on Narcan, naloxone, the opioid antidote drug. But what's really a large part of our work is developing that recovery infrastructure. So we're working with Valley Community Health Center to develop a medication-assisted treatment program. This medication-assisted treatment program would be able to provide Suboxone or prescribed Suboxone, which is buprenorphine. It's a partial agonist to this mu opioid receptor, so it basically helps you avoid withdrawal. It blocks those receptors in your brain, helps you avoid withdrawal and avoid the cravings for opiates. So that's going to be one part of it. And then they also have kind of a counseling infrastructure there that they're developing as well. The other part that we're working on actively right now is supporting individuals who are already receiving medication-assisted therapy. So there's a number of people. The closest Suboxone prescriber is in Thief River Falls, and then in Fargo. So a lot of people are either going to Thief River Falls and to Fargo. And then a number of people from the Grand Forks area are also driving down to Fargo to receive methadone treatment. Between 4 or 5 people right now are driving to receive methadone treatment, and a methadone treatment program is very highly regulated, and it's kind of a challenging thing to do from a distance. So it requires methadone's a long-acting opiate, and it has a high abuse potential. So it's regulated, and you have to, when you start out in a program, you have to do in-person dosing. So you have to have someone watching you take a dose of methadone 6 days a week for 3 months. And then you have one take-home dose to cover Sunday. So you're having to drive back and forth from Grand Forks to Fargo at 6 in the morning. There's 3 hours that you can get a dose a day. So you're driving at 6 in the morning to get your dose to drive back, and if you're working, to get back in time. And so that the economic cost is huge, just in gas, much less your time. But the methadone treatment programs are also considered kind of a gold standard because they include physician oversight or a medical provider oversight. They include counseling at least once per month, and they include that accountability in that you have a nurse looking at you every day, and they can tell if you started using again, and then they can help you get into the counselor or to the provider, change your dose or whatever it takes. So another component of what we're doing is we're providing a travel program to help offset some of the cost. We're providing a little bit of monetary help through gift cards to individuals who are driving back and forth, both in Grand Forks, and it's a program available to anyone in Northeast North Dakota that's driving back and forth. And then finally, one of the other things that we're working on currently is exploring the idea of a medication unit for a Suboxone or for a methadone clinic in Grand Forks. So people wouldn't have to drive 6 days a week. They'd have to drive to Fargo occasionally for some of their treatment, but then they wouldn't have to drive 6 days a week. On the prevention side, we're working on increasing that access to Narcan, the opioid reversal drug. So right now, we've been working with the schools, the library, and the university, and so by the end of January, all three entities will be carrying Narcan in some way, shape, or form. And then we're also working on exploring other harm reduction techniques. We've applied for a small grant to do a needs assessment for like a syringe service program. There's a syringe service program right now that's just starting in Mandan. There's been one in Moorhead that's been around for a very long time, and there'll soon be one in Fargo. But we want to explore the need for that in Grand Forks. And then the other thing is that education aspect. I've been fortunate in my position that there's been a lot of community education going on in the past year and a half, 2 years, 3 years, and that these conversations that I'm having to implement some of my work, it's become so much easier. And so every time that we talk about this, and we talk about it in the manner of addiction as a long-term disease and something that we need to work together to fix, we're getting one step closer to destigmatizing addiction. So we're working on another community event next month where we'll view a documentary and then have another panel discussion. And then we also want to have a speaker to talk about it from an economic perspective too, because we want to work on engaging employers in the business community to realize the impact that opiates are having on their day-to-day as well. Hopefully that wasn't too long.
No, I think it's important for us to know what is happening to address this. And I'm curious, I guess, from either of you, maybe from your long history of seeing this, is medication-assisted treatment a relatively new approach to addiction, or is it clearly dependent on the type of drugs that we're using? But
use that a long time. Alcohol's been anti-abuse, methadones. The new ones, Suboxone.
Suboxone.
Yeah, I always get that in trouble with that one. But we've often had that too. But in the educational perspective, we want to say that some people argue that Narcan, you're replacing one drug with another drug because you're talking about 6 days a week too, with the expense and some of the. So we understand the importance of that too. But we'd like to keep that in line with the behavioral aspect as well too, the education. Alternative training, some people get the Eastern spiritualism exercise and other things as well too, but a combination of that as well too. So it's been around for a long time, and it's hand-to-hand medical community with behavioral sciences, and that's probably the best approach. When you have a complex issue like that, you want the different disciplines coming in and working together. For too many years, I've seen where it became like a one-legged stool. It was law enforcement. We thought we could arrest ourselves out of the problem. You can't do that. It's too big a problem. But with the medical community, the education community, the treatment facilities, the chemical treatment, methadone, like that. If you put that together, you have a four-legged stool, much more sturdy and much better chance of going after a comprehensive a problem that keeps evolving and adapting.
Methadone has been around since the 70s, and then Suboxone has been buprenorphine since the 90s.
Yep.
So Frank, from your perspective, having worked with the population that you've been working with, college students primarily, what have you seen as the shift in perspective on how we view drugs and how we view addiction and the stigma around that?
Yeah, there's always the mainstay drugs. I've been here. I was here as a student in the 70s, so saw the alcohol, the binge drinking. That's still here. That hasn't changed. Marijuana was a concern then. It's a concern now. With marijuana now, you can throw in the synthetic marijuana. You can throw in the new stuff that's a little more powerful, like hashish and the different routes of administration, how to take that. That's a concern, but I think it's even a bigger concern. The marijuana is more powerful today than the stuff we took. More addicting aspect and things like that as well. So we're seeing those mainstays, but I'm seeing a shift in drugs too. And from talking with students and doing my own interviewing and research on there, the new drugs of concern on college campuses and of course high school campuses, Adderall and Ritalin right off the bat, and for reasons are kind of interesting too. A lot of students think that they call them smart drugs. I can study all night long, 8 hours, and we had Vibrant, we had coffee, we did that stuff too. But when you got a prescription drug, when you got a major stimulant like Adderall or Ritalin or Concerta, the handful of prescription drugs, students are using it to study, and they don't always realize this either. Is that sometimes it'll keep you awake, but you might not be able to concentrate on studying. Some people end up cleaning their apartment for 8 hours a night too.
Yeah.
We're seeing that a lot. So there's no such thing I think as a smart pill, but they're using it, and they're also using it quite a bit now too. They combine it with alcohol, so you can drink longer, you can party longer. They're working 40 hours a week. They're taking 18 credits. They start the party at 10 o'clock, 11 o'clock at night, and they want to go till 4 in the morning. And you're combining two, a major stimulant drug with a depressant drug. That's a dangerous combination as well too. So we're seeing that with the stimulant drugs, but we're really seeing a lot of the prescription painkillers. That Vicodin and which would be hydrocodone and oxycodone. The fentanyl we're seeing now out there as well. The opioids, the synthetic painkillers, the powerful stuff. We're seeing more and more of that on campus. And students tell me too, it's easier to get an Adderall pill than it is to get a beer on campus, with the prescriptions. And they tell me, they're pretty honest with me too. They say, Frank, the doctors aren't always trained in behavioral therapy. So you can go there and tell me, I have this bad back, I have this pain, and you can get that. And I was going to add to one of your answers as well too earlier, when we talked about addiction, is that the stuff is so powerful today for young kids. The younger you start, the less developed your brain is. It takes about age 28, 29 to have a fully developed, mature brain. It's like they say it's like a set in cement before it gets hard. When you start using drugs, binge drinking or powerful synthetic drugs, heroin, when we talk about that opioid and that dopamine release, you're fooling with the development of the brain and the parts that are involved with rational thought and stuff like that as well too. So when we have that concern at the college level here too, and people have that availability, that's a big red flag for us as well too. So, but I see that the prescription drugs are being a problem because they're so easy and they're so available, and the internet, powder form, combinations. But they got all the drugs that we had as a concern, and then they throw all these synthetic drugs and the availability, the cost, the purity, and then the combinations. That's what I see changed most. And this stuff is so dangerous now that even though you think you're young and invulnerable, look at the statistics. 64,000 people overdose death every year. When I taught this class 20 years ago, it was 4,000, 6,000, 64,000, and they're projecting more for 2000. These are the 2016 stats for 2007. They're projecting more of that as well too. And heroin is a concern, oxy is a concern. Fentanyl now is I had a speaker today in my class, and she's an EMT, and she was telling us the story. I saw it on news too, where the police officer stopped a group of young men who were using, and they had fentanyl in there, so he was kind of looking over the thing, and he had his gloves on, and he thought it was kind of powder, and it was actually fentanyl, but he had his gloves on, he was okay. And as he got out, and they were talking to the other police officers, one police officer said, "What's that on your shirt?" And the police said, "What?" And when he reached over, a little bit of that fentanyl got on his shirt, and then he had his gloves off. He overdosed from that in fentanyl, and it took him 5 injections of Narcan to bring him back. 3 on site, 1 in the emergency room, and 1 when he got transferred to. It's so powerful, and then that's fentanyl, and all the other prescriptions. But now they got another drug you probably heard about is carfentanil, which is 100 times more powerful than fentanyl. So it drops those big elephants, those, and people are getting access to that on the internet as well too. It's that we have to deal with, and much more, and the stakes are much higher.
I'm going to go ahead and turn it over to all of you. I think this lays good groundwork for a lot of the issues around addiction and what we're doing. So I'll open it up to questions. And Will and Nate, feel free to chime in on the work you've been doing in organizations as well.
I was just going to start Xanax. Do you have students talk to you about that? I was curious thinking about Xanax and how that's another really normalized drug because it's not as extreme as opioids in the case of overdoses. Addiction, though, with Xanax is pretty extreme, however, and I was wondering, with students or just anybody taking Xanax like they do, does that kind of get them into that, what's the word I'm looking for? Or they get used to, just popping pills, you know what I mean? So then when opioids come along, would that necessarily make them more prone to take the opioids? Or how does that?
Habitual.
Yeah, that's what I was looking for. Yeah.
Yeah, Xanax is one of the drugs too. In the last maybe 5 years, I've had several students say, Frank, I think you should do a lecture on Xanax. And I haven't done a lot of lecture on the benzodiazepines, Xanax, Valium, Librium, and those medical, that's psychological drugs too, and that's not my area. But the danger of Xanax too is that, like any other drug, it's a good drug, if you follow the instructions and for a period of time. But when it comes to drugs like Xanax, because it's a depressant drug, like calming, we used to call them sedatives back in our day, but they're sedatives, so they calm or slow down the central nervous system, as does heroin or opioids. And there's a cardinal sin when it comes to misusing drugs. You never combine two depressants, because both of them, they not only occupy the opiate receptor sites and give you that feel good from the dopamine being rushed out, but it also slows down your respiratory effect. So when you put two of those together, they call it synergism. Two might have the effect of 10, and we're seeing people overdose with Xanax and alcohol. Xanax and some of those more powerful opiate drugs. Heath Ledger's a good example of alcohol and Xanax. And we're seeing much more of that now with the benzodiazepines. When they first came out, they were supposed to be a safe alternative to the barbiturates, which a lot of people were dying from and overdosing from. But that was a myth. People were overdosing from that, and then we're throwing it on to another depressant drug, and we're having that concern as well too. And then with any other drug, when you are younger and you're taking it more than you're supposed to, or you're misusing it, or we say using it offline or off-label, the addiction can be much greater as well too. So, and once you develop a tolerance for Xanax, that's going to affect your tolerance when you're taking heroin as well too. Cross tolerance becomes a very dangerous thing as well, and we're seeing that younger and younger and younger, the college, and even in high school I get a question about Xanax now. But the benzodiazepines.
That actually leads me to my follow-up question with that. So, because every decade or so, it's kind of shifted. You had the ice, and then moved up. Was there a precursor then to the opioid crisis that's going on now? Like, was there some sort of red flags that happened, 10 years ago or so? And are those same red flags prevalent with Xanax?
That's a very good question here too. And like I said, Xanax and the benzo are a little bit out of my area. Maybe Mike can address that question too. But I will say this about the other drugs though. They call it in the law enforcement field, they call it whacking the mole, which means that when a new drug comes out that's illegal, in law enforcement, they're gonna arrest, they're gonna slam that down, what they did with meth and crack cocaine. But when you do that, when you clamp down on a drug, another drug is gonna pop up. And that's what's happened with these opioids, is that when they clamp down on heroin, when they clamp down on the other drugs, because of the addiction or the feeling you're going to get that, another drug is going to pop up or another combination. And I think that's what happened on that illicit part. As far as the medical aspect, I'm going to be careful of this too with my medical colleagues as well too, but boy, most people point to it just been overprescribed. It's just an easy thing to prescribe it. There's in our field in behavioral sciences too, it's called addiction by prescription. And you take Xanax or any of the opioids, they're so strong that if you were given a legitimate prescription for 30 days, you can get addicted easily in 30 days. You can get addicted probably on this stuff in maybe 12 days if you take it steady. I went in for an infection on my wisdom teeth, and I had an infection from getting wisdom teeth taken out, and pain I've never had before. They gave me everything, Percocet, morphine, fentanyl was finally got me out of it, managed it too. But when I left there, the doctor gave me a prescription for, I don't know how many hydrocodone, which if I get in, my dentist gave me another one. And I don't like to, I'm kind of a guy that's like staying in control. I only took probably 2 of them, but my sisters and relatives, must have had 120 of those. Those are $60 a pill, on the street. I had hundreds of them too, but they just took them and used them when they wanted to. But it was so easy, and I think that addiction by prescription, and then look at Prince, this most recent example of prescription drugs, and he was the guy that didn't drink. He was a vegan. He was into healthy. He didn't use any. He frowned on recreational use, so I'm sure he didn't smoke marijuana. But he had an addiction to prescription drugs, and I think it was that fentanyl that the tolerance that he built up, and he had access to doctors, they think same with Michael Jackson. You do the same thing with Anna Nicole Smith, River Phoenix. It's the same pattern there too. So the whacking, another drugs popping up. The benzos popped up and they clamped down on the barbiturates. They got a handle on the barbiturates. The other ones are popping up and the more powerful opiates too. But as far as the medical prescription, I'll leave that maybe to Mike.
So that is halftime. We're going to cut the file in half there. So we've got about another 45 minutes of the rest of this event. And if we don't have it be our episode next week, we will at least share the whole audio clip online. You can watch the rest online, I think. We'll make that decision soon. But the rest of it's really good. I think it gets better on the second half, actually. But I also liked hearing the introduction of Michael and Frank in this half, and especially Michael's explanation of what the city is up to as far as planning these harm reduction things. What do you... I was really excited when I first heard about that. He was describing they want to build a robust system for treatment, including Suboxone providing in Grand Forks.
That was very encouraging to hear that sort of tone, that harm reduction tone, is gaining a little momentum even within the realm of, the city. Local legislators and stuff like that are even kind of catching this general idea of what harm reduction is and, sort of why it's important. One thing in the discussion that really, popped into my mind that I think a lot of viewers and a lot of people in general that are not super, super familiar with harm reduction and drug use in general, I think one big question that will come to people's minds is, why should we help these opioid users stop their withdrawals? Why does that matter? Why is it important to help them stop withdrawals? And that's a good question. I can see how people wonder that, I would likely even have wondered that kind of thing before I had ever experienced what addiction was firsthand. And I think, it's really important because they mentioned during the discussion that people will resort to just about anything to avoid those withdrawals. The withdrawals don't typically, from heroin and opioids, the withdrawals don't typically kill its users, but they are so uncomfortable that users will oftentimes resort to just about anything to avoid that withdrawal.
And I think that's the answer. Why, to the question when my parents or somebody ask, why would you ever do heroin, or something? Why, they just can't fathom somebody making that decision. Mm-hmm. And I think a lot of the people that make that decision are ones who are feeling the withdrawals from their other opioid sources that now they can't get or don't have available.
Yeah.
So that's what, they say they'll do anything. The first time I ever really experienced somebody who's going through withdrawals was when I was at a music festival in Colorado. This guy was hanging out with us and whatever, he was fine. And the second day he was totally sick, and I let him lay down in our tent, and he slept in our tent all day. He was so sick that, I'd never seen anyone in so much pain. Like, if this dude's mother would have seen him right there, if she's anything like my mother, she would have done anything to fix this, anything, because it was just horrible to watch. And he's not faking it, this is a physical reaction. And what happened was he had to have a friend come up from Denver to pick him up, bring him home so he could medicate himself. He said too, he's like, I'm going through withdrawals right now. I thought I was going to be okay for the weekend, but I overestimated myself, and I am really feeling it, and I don't have any medicine with me.
Wow. He himself underestimated the power of the withdrawal.
Yeah.
Wow.
He knew that it was a possibility, but he was confident in his ability to be okay this weekend, but he was wrong. Mm-hmm. And so he had to have a friend pick him up, drive him all the way home to medicate himself, and then he drove all the way back for the last day because he had a weekend pass, and he was totally fine on the last day, totally fine, not high or anything, just his withdrawals had been cured and he was able to be himself. But that was a good experience to me because I finally understood what withdrawals mean, And I mean, think about it. If you have like children or like, you know, a job or anything that you got to go be at to survive.
Yep.
And you can't be there because you're feeling bad. I mean, I totally get why you would resort to doing something dangerous.
Mm-hmm. And that's the answer to this question. Why should everybody care about helping these people? And the answer is because people addicted to opioids will resort to nearly anything to avoid that withdrawal. And as you pointed out, this guy, once he got his medication, he was able to function normally.
Yeah.
He was able to like function normally. And you mentioned they could go to their job, they could do their normal things once they have this the opioid receptors in their brain and body filled. And that's why things like Suboxone and methadone and just opioid treatment in general and drug treatment in general is so important, because you can help people function normally in society that otherwise would not be. They'd be resorting to anything to avoid those withdrawals.
You know what else I really liked about this conversation was how Michael was talking about how he uses Reddit, the opiate subreddit. So Reddit, is a website. It's like a online community building kind of website, and there's different categories you can kind of subscribe to, and you often get really sincere stories and information from people on certain really specific topics. So Michael was saying he uses the opiate subreddit, and he is a part of that community, or at least reads what's going on there, and this is how he's learned, a lot about the drug community and how people are trying to educate themselves and stuff like that. Mm-hmm. Really great how he is clearly seeing value in drug users' perspectives on drug use, because last year, our video was kind of critical of the fact that it seemed that the city was, one person on the panel who said we should not listen to drug users because they're biased in the conversation about legalizing or regulating drugs. But now here, this new city employee who is the Opiate Response Project Coordinator probably had on his resume that he is aware of the subreddit opiates, and he, deliberately uses these online sources to communicate and learn from the stories of drug users is a really good sign. That's very encouraging. Yeah, like to have that sort of inside perspective. Like he invested his time, got on this Reddit, and was educating himself about drug users and their perspectives and stuff. And that was very encouraging to hear that he is involved in the community, and so he has a little bit of impact on the way the tone is changing. Yeah, our questions, I think we'll get to more of that in part 2, or the rest of this clip, is we ask him about the tone of these events, and he says, so he's new to this, right? Like, he lives in Fargo. He's just been commuting up. He just started the job last month. Oh, okay. And so he's got this grant, and he's put in charge of a lot of stuff. He's learning a lot. He's figuring out what his role is, I think. And they all are. But so he wasn't around last year for these other events. All the other people on the panel and in his group, I think, were. And, he's just a part of the team now. And so he's learning about what the tone is. I really like his tone, and I like how he was able to talk at this thing, and he seemed open and sincere and really cool. And there were some other city folks there who were, totally vibing off of him too. So, yeah, that's super cool to see. Like, from last year, don't listen to drug addicts when thinking about drug policy, and then here this year, this guy is doing the exact opposite. He's like, no, we need to consider, drug usage and the inside perspective. Yeah, and I think it seems that the rest of the city crew and the whole mayor's call to action and all that are really behind him and behind a tone like that. That's wonderful. They hired him, so. And I just met him, maybe we don't know him that well either, but I got good feelings about it all. Wonderful. So Frank, wonderful. In this thing, he described what the word epidemic means. Yeah. In the same way he explained to us what psychedelic means. The psyche of the mind, and delic, expanding or manifesting. Mm-hmm. The Psychedelic Club is about expanding our minds and all that. He taught us that. I liked how he said about epidemic. Epi means upon or around, and demic refers to the people. So there's just something upon or around the people, and that is the epidemic we've been calling this drug epidemic. But it just got me thinking, like, maybe there could be a good epidemic. Something good can be upon and around the people too, right?
It feels like that's catching on, that there is sort of this movement of goodness, this movement of, genuinely involving yourself in this Reddit, like this guy did, Michael did.
What if it's a psychedelic epidemic?
A mind-expanding epidemic.
All around the people.
That's good. That's a good thing. It feels like things are going well. Momentum is like going forward in a good, positive way.
Well, thank you all for listening. This has been the third episode of the Harm Reduction Report. You can catch us live every Tuesday mornings at 88.3 FM KEQQ Grand Forks. Or online, our Facebook, the UND Psychedelic Club Facebook page, or sandbaggernews.org. Thank you. I don't know, I guess if we'll have part 2 on next week or go somewhere else, but we'll let you know. Excited to see you again. Thank you all, and sandbag on.
Thanks. Your pal Cal here, signing off. Thanks for having me, Will.
Toodaloo. Hi, everybody. Welcome to the Harm Reduction Report. This is Willard T. Belly, Sandbagger News. You'll be hearing from your pal Cal at the end of the episode, too. Today's episode is going to be part 2 of Kylie Oversen's Thirsty for Justice Thursday event that we covered last week, in which the advisor of the University of North Dakota Psychedelic Club, Frank White, UND professor, and Michael Dulitz, the new Grand Forks Opiate Response Project Coordinator, talking about addiction. It's a really great conversation, one I'm happy to be a part of, and we'll have a little discussion at the end after we play the clip. Just so you know, it's Monday, December 11th when I'm recording this initial opener here. The UND Psychedelic Club is currently waiting to hear back about the sessions that we submitted to speak at the Students for Sensible Drug Policy Conference in Baltimore later. We'll let you know as soon as we hear back about that, if we get to speak more. But for now, let's listen to Frank White, Kylie Oversen, and Michael Dulitz, Part 2, Thirsty for Justice, talking about addiction and good old G-Funk. Thanks for listening, everybody.
So heroin's always been kind of a background drug. It's always been there, but what really got it up to this epidemic level was in the early to mid '90s. A couple of drug companies put out new medications. OxyContin was one of them, and then there was also the Vicodin, and then a couple other along that. Opana was another one. And they put out these medications, and they accompanied it with a campaign, pain is the fifth vital sign. So they encourage people to, or they encourage healthcare providers to always ask about pain. What's your pain on a 0 to 10 scale, 0 being no pain, 10 being the worst pain of your life. And the research that they used behind that, or the research basis behind it, they were saying that 99% of people don't get addicted to opioids when they take them. And then you look at the reference, and then you look at the bottom, and then it says it referenced the New England Journal of Medicine, and so people didn't really question it. While you look at the actual article that they're talking about, and it was a commentary piece by an individual saying that in my practice, I've only seen it in 1% of my patients. So it was very much a misleading statement by the drug companies. And by the time that anything had happened, there was a lawsuit in the mid 2000s, I believe. By the time that it happened, the opioid prescribing had become so commonplace, yet we didn't see a problem yet because people were still obtaining their medications legally. And then And then we started to see overdoses of prescription medications from people using like Oxycontin, stuff like that, snorting it, injecting it. And so then that peaked in the healthcare realm. And so then healthcare practitioners started cutting people off, tapering people down, sending them towards all these other types of therapies, but there's still an addiction there. And so that's when that's kind of when the heroin started to peak, because it's affordable. If you're trying to buy your pills illicitly after being cut off by a physician, most of your medications like oxycodone, Vicodin, things like that are about $1 per milligram. And when you're using 60 to 100 milligrams a day, at a time, one of those, it can become a few $1,000s a week habit. So that's when you go to the heroin, and then you build up with the heroin, and then you start injecting, and your heroin is adulterated with things like fentanyl because they're trying to get more heroin out to people. And so that's why we've ended up with the overdose deaths, and why it's become such an issue.
And you look at America, you look at our population, we have about 4%, maybe 4.5% of the world's population. We consume 80% of all the opiates in the world. You don't have to point the finger, it doesn't take very long to connect the dots or two. Overprescribed, it's too available. And even if you don't get it from your doctor, you can go on the internet, too, and you can have that delivered,
There was a vacuum there that was filled in very quickly. And when you go online, basically out of China, there's, fentanyl is illegal, and there's a lot of analog drugs, where they change the composition slightly, but it still acts the same. There's a lot of analog drugs, and so they keep migrating to different analogs, and so now you have lots of different types of fentanyl. The two most common are the fentanyl and the carfentanil, but there's cyclophentanol, there's and there's U44700. I may have that a little bit off, but so you're migrating through that. Now they're purchasing pill presses, and they're making them look like oxycodone or stuff like that. And it's fentanyl.
They had a big story last week in Bison National where they had busted one of the labs in China and shut it down, which is a big deal. But the next story was that there's probably conservatively 160,000 labs like that just in China. So when you outlaw one drug, you just change the molecule a little bit. This is how it happened with Molly and the other drugs too. Just change the molecule, and you have 450 waiting online to go back and sell that. And you can buy fentanyl pills, or you can buy fentanyl powder, and people can concoct their own things too. Sadly, it's almost that easy.
Yeah, and it's hard for there has to be a fairly good case to open somebody's mail, and so a lot of the way that a lot of opioids are being passed around is through the mail. So,
and like I said, we'll never enforce ourselves out of this problem because changing the laws has virtually no effect on internet commerce. That's going to keep growing too. That's the key one that has got to be addressed, and that's a big one.
Do we understand the why of addiction? I mean, from a physiologic and psychological and sociological perspective. I mean, that's, you talk about how, this substance, then the other substance, and if you really look about prevention from going all the way up the stream to universal prevention, the ideal would be that we would eliminate the need for people to become addicted to various substances. What is it? I mean, what do we know? And do we know anything different than
the idea of addiction itself is a very good question. We just started understanding addiction pretty recently. I remember in 1979, we were still, when I was in grad school, talking with the Wilson Act, we were just kind of getting this idea about addiction and learning about this, especially when it came to female addiction as opposed to male, a whole different biology. And when we talk about addiction, it's if you talk about the World Health Organization, the medical community, the sociology or the liberal community, they have different definitions too. Social work, and what I do to explain it, and we just do it like anything else in sociology. We operationalize the definition. We come up to a common understanding with what we think is a handle and how we can address that. And I pretty much break it down simply. When we talk about addiction, most people give the definition. It's a continuous or repetitive use of a substance or an activity, video games or a phone or a product, despite negative consequences. You're doing it, and you're doing it despite responsibilities or relationships or family. Okay, so when we look at that, the addiction, it's pretty much a addiction of the brain. It's a neurological aspect. Not everybody buys that as a disease but I think the research pretty much supports that over the last 50 years, and we're seeing that too. And I just break it down into two different groups, addiction. There's a psychological component, as you mentioned, and that's those cravings that we talked about as well. And you know this when you're addicted to caffeine or cocaine or whatever your drug of choice happens to be. But when you take it for a while, you develop those cravings, and you can tell it in a person or yourself when you don't get your coffee. You're irritable. You can feel those cravings, those urges. There's a and maybe even depressed and fatigued or trouble concentrating. That psychological aspect, and you know that if I can just seek out that drug, and I'll be happy again. I'll be able to concentrate. I'll be able to function. So that craving is a very powerful aspect on a psychological level. But the other one is the physical level. And you use that same substance over a while, the body physically changes. The brain physically adapts to the presence of that chemical. And on the physical level, there's basically two levels. One is tolerance. Is that you take a drug and your body's going to create enzymes. Anything you put in your body, alcohol, if it isn't food, it's going to be looked at as a poison, intoxication. And the liver and kidneys are going to create enzymes to try and neutralize it, rearrange it, make it useful, and get it out of your system as quick as possible. And when that happens, you build a tolerance. So these powerful drugs, opioids and methamphetamine, you can not develop tolerance about that, but very, very soon. And you have to take more and more of it, and that's when you start changing. You talk about stuffing, and there's other, snacking, and all the different ways you change that, or you combine it, or you take higher dosage of that to get that same feeling. It takes reduce sensitivity. You've got to adjust for that. That's a dangerous game. They call it chasing the dragon. Mm-hmm. And then the other part of physical addiction or dependence is the withdrawal syndrome. If you take that drug long enough and you stop using it, your body's going to go through withdrawal. And if you go through withdrawal from alcohol, that's life-threatening. When you go through withdrawal for heroin, that physical level is, people tell me, so they'll never use again because that was so hard to get through too. So physical and psychological, and so intense that people will keep continuing to do that in spite of the responsibilities, in spite of the consequences. And I've come around slowly to absolutely believe it is like a disease. It is a disease, medical aspect. And students tell me this too. They go, you know what, Frank, it's not like, cancer, you have no choice in that too. And I go, well, cancer is probably a bad choice. Think about it like heart disease. Like my family's, we have a lot of I'm Native American French, and we have a lot of heart disease in our family. Diabetes, high blood pressure. We know that when I have heart disease in my family, if I'm careful with what I eat, if I watch my weight, I watch my blood pressure, there's some medical intervention. I talk to my Dr. Mann every 6 months, and I do what I'm supposed to do. It'll improve my quality of life. And that's, I think, is I look at it like heart disease as opposed to cancer, something like that too. But it is a psychological and a physical disease of the brain, and we can see it, we notice it. It fits the definition of that too.
I guess my question though is more about the why. Do we understand the why? Like why we crave to do things, and to me that's the $1 million.
The drug seeking behavior.
If you're gonna prevent it.
So the hard part about the why in the opioid epidemic is the why started, or for a lot of people started, as a result of a pain or some sort of trauma. Whether it's medically induced or a medically induced trauma, and then afterwards you have access to opioids and you start using it to treat the physical trauma related to that. So. Example of, if you're in a car accident and, you're a sole survivor or something like that, you're injured, you use opioids to get through the physical pain of what happened, of the injury, and then you start to use to manage the emotional pain as well. It gives you that warm feeling, it's like a blanket over you saying, it's going to be all right. And so that's when you start going down that slippery slope, I guess.
Yeah. The motivation is different from the drug too. As you said, opiate, heroin, fentanyl. Most people that are the motivation for that too, is that they're in a great deal of pain. They're in a great deal of psychological pain. They're in a great deal of physical pain. Look at the people that have OD'd, just the people we see on television. There's hundreds of other people, thousands of other people, but look at the people. Look at Philip Seymour Hoffman. You know, they die alone in a hotel room. They got everything. You know, Whitney Houston drowns in her tub. You know, Heath Ledger, Prince. You can go on. Michael Jackson. They're dealing with a psychological pain over a long period of time, and with the tolerance and the increases and the accommodations that they have to. That motivation is for psychological, as you mentioned, and the physical pain. Now, stimulus is a little bit different now. That has to do with, you know, like attention and energy and partying and coming up after you've been drunk all night long, you know, to stimulate yourself. So the motivation is different for the drugs, but because we're doing opiates tonight too, that has been, with the counseling in the field, it's pretty much the psychological and the physical pain. And we talk about self-medicating, it works short term.
But I think to the question, Jane's question, I think what's really interesting is I'm not a doctor at any point, the mental part, the brain science part of it, the why addiction, and it's not just the negative side of it. I know when I don't work out for 2 weeks, there's a physical response and a mental response, a psychological response that I'm just a jerk, right? I know that I don't feel well, I'm sluggish, I'm not as sharp, and that has nothing to do with imbibing any sort of chemicals or anything like that, but there must be some sort of chemical, something happening, something in my brain. And I know we're doing enough research now with trauma, particularly with kids and resiliency and trying to rebuild some of those things, that there has to be something going on that's beyond chemical intake if these things are happening. And how are we looking at that? How can we go way upstream to start looking at addiction in that sort of capacity, so we can do things. So even, not that I want to replicate not working out, because then I'm just going to become addicted to cheese popcorn and get all chubby. But how do we recognize those types of things and have those types of responses way upstream, so we're not talking about this anymore?
Who's the psychologist from Grand Forks who's retired now that talks about healthy addictions and exercise as an example? It runs all the time.
You have endogenous opioids, so you have opioids within that your body produces. Yeah, and that's exactly what a runner's high is. You know, so it's on a similar level. You know, your body's always trying to, you know, self-regulate, and so you know, drugs kind of change that self-regulation method a little bit. And so yeah, I think if that's, you know, maybe another why answer is that, you know, you do have these within yourself. And, you know, are you able to activate them or not? You know, is there this is kind of going into a side tangent, but, you know, do you have that meaning in your life, you know, that you can activate, you know, what makes you happy, you know, your endogenous dopamine or dopamine receptors or opioid receptors, you know, so.
In my area is sociology, so we look at the environmental, and when you ask about the psychological, the person I remember reading about, and probably an expert in this area, Dr. Andrew Weil, W-I-L, and he thinks that you know, drug-seeking behavior, or that quest to alter your consciousness, is like the fourth drive. Like you have sex, hunger, thirst, and that might just be how we're wired. And that area has gotten 40 to 50 years of research in there as well too. So I think in the psychiatric field, and when you talk about endorphins and runner's high, I think you have that aspect as well too. When it comes to addiction or drug use, I think in most cases, you usually talk about moderation. Running is good until you become addicted to running. You're running and you're not talking to people anymore. You've ran too much, you've lost too much weight too. So when it comes to, you know, you lost connection with your friends, I think in that real area, I think there's a lot of that in the psychological, which is more the individual, the genetic, and fascinating, but I wouldn't have much in that area. So we look at how the environment affects that too. So, and in my class, I say, you know, look at addiction. It's a complex combination of your environment, your genes, and then your personality. Some of us have personalities, especially adolescents, risk takers, you know, part of the brain that hasn't developed yet as far as rational thought, you know, the impulse and emotional. You look at personality theories for the motivation, and then you throw that into the environment where there's a lot of peer pressure. social media glamorizing drug use, and then you get a personality that's guys who are showing off are invulnerable, and that gender bias erased on women doing the same thing, drinking like guys. You're starting to see that as well too. So probably again a combination of those three areas, and I think your question motivation would probably be more fulfilled in that psychiatric field.
Yeah, and to touch on that too, drugs basically amplify that extra release of dopamine. Then when you don't have the drugs, it basically doesn't have something telling it to shut it off. You know what I mean? So then your neurons are like, hey, where's my dopamine at? And then that's when the withdrawals, at a very basic level, start to happen. And it's kind of, I like to look at it in line with things like Parkinson's research. That's what I did at the med school for a while. And it's working in the same system, like dopamine, and even similar receptors, more or less. But I guess if you look at it, it kind of boils down to like a funding thing. Across the board, funding with like education, definitely with research. But I guess one of the golden questions is, where do you get the money from? How do you increase the funding? Because, from what I've learned, it seems like, we still don't have cures for things like Parkinson's, like Alzheimer's, or any of those things. And a lot of that is because of their funding. So it's the same situation, more or less, just spread out. But that's a good question for both of you guys. Like, how do we get more funding for this stuff?
Good question for Kylie. Working with the legislature and the funding and budgeting.
Well,
There's a discussion of most of our tobacco funds, and the reason why we've had such a good job at addressing tobacco, which I think is one of our biggest public health successes in the past, the past 50 years, was because they sued the tobacco companies and they won a substantial amount of money because they misled people. And so there's been talk of a similar lawsuit against pharmaceutical companies because they misled people, and they created a lot of it. So
Valley Community Health Center,
yes.
Is that working to develop all of that in Grand Forks, or are you just working on one piece of that? And what are the barriers that you're facing in creating something similar in Grand Forks?
So what we're doing with Valley Community Health Center right now is to be able to prescribe Suboxone, you have to go through a waiver program. So for physicians, it's an 8-hour class, and then you have to get a new DEA number. It's a DEA X number. And then for advanced practice providers, it's 24 hours. So that's kind of a barrier to people wanting to get into this realm. Much more than people just having a willingness to prescribe. It's a willingness to prescribe plus education and DEA hassle. So we shared some of our grant funds with Valley Community Health Center to work on developing this program. And so they have one of their nurse practitioners going through the training, and then another one that's working on the training as well. And then the state has money designated for what they call a champion prescriber program. So there's two main opioid treatment organizations in North Dakota, Heartview out of Bismarck, and then Community Medical Services out of Minot and Fargo. Heartview was here first though. And so we're working with those organizations to put together the necessary framework to have a high quality program, because we don't want to just prescribe Suboxone because, he was talking about that one-legged stool. It's the same concept. If you don't have that, support for, maintaining your health, support for counseling and, staying, social support, you aren't going to get over, or you aren't going to have a good outcome from your addiction treatment. So we're working on building that infrastructure with Valley Community Health Center. They have they have a counselor, and they want to add a social worker related to both this work and their community health center work. So that's what we're trying to do with the Suboxone side of it. And then we're exploring the idea of increasing access to the methadone as well. So the big barrier right now is is the stigma behind medication-assisted therapy, which isn't, as much of a stigma with the individual, but it is within the addiction treatment realm. So there's a lot of people that still think abstinence-based treatment is the best way to go and the only way to go. And so trying to get individuals like licensed addiction counselors that think along that line to refer people to medication-assisted treatment programs can be very challenging, as well as some of the existing infrastructure like organizations like Narcotics Anonymous. They're relatively anti-medication-assisted therapy. So, within the healthcare realm, a lot of people just don't know about medication-assisted therapy. They hear methadone clinic and think a dirty word, where people are diverting medication everywhere. So, we're working on that. We've met, with our with leaders at Alter. We've met with community leaders in other realms as well. We're working on getting this this infrastructure built.
And I don't know if this will be a problem in Grand Forks, but I know with Hartview and the Bismarck-Annan area, when they were creating their methadone treatment program, I think one of the barriers was the stigma of the community of creating this facility for drug users to be coming into, and so there was a lot of conversation about just the perception of having this type of facility. I don't know that will present a barrier, but I think they actually had zoning problems because of it.
Minot had
Minot did.
Bigger issue because Minot was the first methadone clinic in North Dakota, and when CMS Community Medical Services came to Minot and said we want to open a clinic here, they enacted an ordinance that made it forbidden for I think 2 years or something like that, and so they came back to them and with a better proposal, different company, better proposal I guess, or something like that. I don't remember the specifics, but when they came back with a better proposal and they started building some steam, the chief of police from Minot actually went to one of the other community medical service facilities in Montana and staked it out and sat outside there, didn't tell anyone about it, and watched to see what happened, what it was like during dosing hours, what kind of interactions were happening in the parking lot, people going in and out, and he was pleasantly surprised, and he brought that information back to Minot, and now Minot has an active program. So
I think that's key too. I think it's something we all agree on too. Part of prevention is education. If we can educate the public, and so they know that what that information went back with, so the legislators and the people who are voting know that it's not about another drug. It's more enlightened. That's how they got medical marijuana passed too. They start talking about the archaic laws and how they were racist, and people, especially the younger generation, when they got this information, I go, that stuff is kind of draconian, but you have to get the money for the prevention, for the education, for the awareness, and I think that's what we're woefully behind here. Not just here, but as a country as well.
Cheryl.
Yeah, I don't know if you can address it in terms of it. It's sort of linked to the education, prevention, and Frank mentioning about addiction by prescription. If you can, what are the efforts that are being directed toward the medical community? How are they responding? And when you talk about money and things, it seems like, at one layer as well as a doctor, our understanding of pain management, that's where some of the money needs to be directed. Right now they have a pretty rudimentary way of diagnosing pain through pictures. So even starting at that level, because I can imagine being a doctor, you have patients, we have a culture that wants to be pain-free. What does pain-free mean? And then you walk away with these month prescriptions. So I can imagine, there's a lot of tension there. Are there efforts to educate the medical community, and how are they responding?
We're seeing a little bit of that with the prescription are coming out to. They don't prescribe 30 days; they prescribe 15 days. So, but it seems to me that those are small steps, and I don't know enough about it, but I tend to be a little bit jaded when you look at the lobbying groups. You look at big pharma,
Right.
The money, and how that works. I'm guessing that the pressure we're seeing is a Band-Aid, lesser amount of days. But I think that is the concern there too. And if I can just use another example, was to when it comes to Ritalin and Adderall, and attention deficit disorder. We have almost all that in America. Worse, France doesn't even prescribe that. They don't believe in that hyperactivity, and so we do a lot sometimes. And I'm told this from the research is that we do it sometimes just to get the kids to behave in school or not for a while. And other countries don't have that belief system too. So I think we're unique in a way, but I think a lot of it's because of the economic engines that are driven, and the politics and the lobbying groups as well to it.
You talked about
And that's your area, but I mean, that's what we in sociology we're critical of those institutions and capitalism and the good and the bad of a critical perspective.
You mentioned the drug companies, instituting the pain and starting that demand, but has JCOS changed their requirements because hospitals and clinics were required to have that
so
medication, the pain scale.
they're working on migrating away from that. That's something that has to happen on a legislative level as well as on our administrative level, not legislative, administrative level with like Medicare, because they require certain metrics on their on some of the surveys that they put out. Did we manage your pain well, things like that. So I guess if you're wondering like what's happening now, the one of the first things that happened was the PDMP, the Prescription Drug Monitoring Program. So that takes all scheduled medications, so any medication really with an addiction potential, and it sends the prescription information to a centralized database. So a prescriber in Dickinson could find out if someone from Grand Forks had a prescription for an opioid, and someone in Grand Forks could find out if their patient from Florida had a prescription for an opioid in Florida. So it's nearly national, very close to being international or nationally connected, this monitoring program. They're also working a lot on prescriber education, and that's been something that's really been taken on by a lot of healthcare systems internally. So really that's one of the things that's been an easier part of our grant work, because they've taken this on so much internally. The unfortunate side effect was that they've really, with the change of prescribing practices, that created that vacuum that we talked about earlier. But then along that line, they've been working on, individuals on long-term opioids, are moving them into a pain management type specialty clinic. So they look at, their pain along, or, what they can do with opioids versus what they can do with a lot of other types of treatments and therapies, and they look at what triggers your pain, and they look at it from a psychological perspective. They look at it from a physical perspective. Can we do something to treat that pain? Can we provide an injection to treat that pain for a while, things like that. And then they do look at it from a pharmaceutical perspective. What can we do to do that? So the pain management realm has really developed in the past few years, and it's become very multidisciplinary, which I think is a net positive. And then along with that, that change in prescribing practices to limit the initiation of opioids. So, if you're in the emergency department, they track, how many opioid prescriptions, provider puts out, based on the equivalence of morphine. And then, they look at, can we try other therapies first before we give you an opioid, or an opioid to take home. And then the final piece that comes to mind is that pharmacists are now allowed to do partial filling of opioid prescriptions. So when you go to the pharmacy, they can say, okay, we'll fill 2 days worth of your opioid prescription after you come from the hospital. Then you can come back and get more, and that helps control the supply a little bit and makes you think twice. Do I need more of my hydrocodone or whatever?
Well, that's what I was surprised with. Frank saying about his wisdom teeth. I had a colleague who had undergone surgery, and major surgery, so I've been on everything you could get on morphine and everything before, and then afterwards as well. And was sent home with a 30-day supply, and he recognized that he was getting addicted.
Mm-hmm.
And he said the withdrawal, even after a 2-week period, not even quite 3 weeks, was really painful. And he recognized that and went back to his doctor and said, I don't want the rest of this. And the doctor refused to take it back.
Yeah, and they've developed those take-back programs now. So nearly every pharmacy, or a majority of the pharmacies, I guess I should say, in Grand Forks do have a provision for take-back. So it's a big box, and then you put your medication in there, and then there's something in there that renders it inert. So it ends up going to Bismarck, and then Bismarck gives it to the DEA, and they incinerate it. And then also the law enforcement offices at both UND and downtown in Grand Forks, as well as most of the law enforcement offices around the state have take-back locations. And I know Alchu has quarterly take-back events too, except for the winter quarter.
Can I ask a random question?
Sure.
You were talking about Narcan. I've heard I'm on the student relations committee at the university, and I've heard different perspectives. Ones that I was surprised about from, I won't say who, that really didn't want to have it on campus. Is there consideration of bringing Narcan to campus? And I understand the issues, but I'm also Canadian.
Well, if you want the latest news, I met with UPD before I came over here, and they're going to have it by the middle of January. So we're going to start training the UPD police officers the second half of this month. So.
On Wednesday, there was a student senate meeting, and I think they voted to pass a bill.
Yep, and I've been working with that student.
Yeah, with Tristan and his group called Students for Opioid Solutions.
Yes.
Yeah.
We've been working for that for 2 years though before this happened.
Yeah.
We ran through this administration, the conservative brand of UND.
Yeah.
So I get all that too, but I was pleased to hear about the recent progress, and I think that's just a good deal. But it's a long time coming.
Yeah.
So the big concerns with Narcan is that you're giving people a reason to use more, and that it could that they're just going to use more and more because they know that someone's going to be there to rescue them, and that hasn't really played out in any type of research as being something that motivates opioid use. And then they talked about things like they call them Lazarus parties, or where you have you get together with your friends and you all inject and you try and push farther and farther, and one of you will give you Narcan if the other one overdoses. But again, those haven't really played out. It's more of a hysteria thing. Yeah, it's a hysteria type thing. It's not really something that's actually played out.
Michael, I'd really like to ask about the upcoming city events that are being planned. You mentioned last April there was a film screening at the Empire downtown, and my friend Maylee Smith was hired by the city and the university and the hospital. I think we're all producing it to make a documentary about the kids we grew up with in Grand Forks who died. It was called Faded, and maybe your high schoolers had watched it.
Yeah.
We were the UND Psychedelic Club. We're also a chapter of the Students for Sensible Drug Policy. We were there filming the question and answer panel that happened after the film screening. And when I talked to May Lee the next day, she told me, I was really surprised that she was actually really horrified with the tone of the panel. It was completely the opposite of her point in making the Faded documentary. She said they didn't want her to include a lot of the harm reduction stuff and the what are we going to do about it stuff. They left in all the sad stories that had me and everybody else bawling our eyes out during the thing, but didn't want to talk about the harm reduction stuff about it. And
it was just the just say no approach.
Yeah, it was the just say no approach. And Chris Myers, the U.S. attorney for North Dakota, I don't know if he is still, he was there talking, and he had said that there's this whole thing, hashtag Narcan me, that people are saying, and that it's, having Narcan available is going to encourage people to abuse drugs more. And he said, just go on the internet and look at hashtag Narcan me. Well, I did, and the only where anyone on the world of Twitter had ever said hashtag Narcan me was him in a news article saying it happens everywhere. So
They solved it with a commercial with a broken egg in a frying pan.
Yeah. So the tone doesn't seem to be very sincere when it comes to stuff like that. So.
You're right, Will, too. It's the same story, and as you mentioned, Cheryl, before about the reefer madness, too. Same with drug education. If you give out condoms, everybody's going to be having sex, too. Go free needle, everybody's going to be IV'd. And that isn't the truth. They call that negative education, which is the opposite of prevention. What we're trying to do with the Harvard Rescue Club is to get good information out there, too, to show that and to raise awareness. But a lot of people believe that, just what you said, that it's not just the local level either. I said the national war on drugs, zero money to harm reduction. Maybe the discussion of the time, all harm reduction isn't like using drugs. It's education, methadone, drug testing. A lot of people overdose because they think they're getting Molly and they're getting meth or something worse. So when you've been to those places in Denver and people drug testing tents and kits and do. UND's hasn't been very helpful when it comes to having those on campus either, as far as what someone's taking, drug tests. But,
it's in the pipeline.
Yeah, it's in the pipeline, and that's what I heard a long time ago too. But and in the meantime, you're losing your classmates, you're losing your friends.
Yeah, and somebody else at that city meeting last April at the screening, the Dr. Bo from ER at Altru, who seems like a really sincere dude, also said that anybody who wants to legalize drugs or talk about regulating drugs differently is biased because they must use drugs. And people who use drugs because they're biased, we shouldn't listen to them in the conversation on what to do about them. And he said that, and everybody applauded before he was even finished. And, when you hear things like that, it sends a message to people like, I'm not supposed to be a part of this conversation. They're not going to listen to me, even if I were to speak up about somebody who's using drugs. So I'm wondering what the tone of the next, city events are going to be like.
There's definitely, even with the people that were on the panel, it's obviously a very evolving thought process within themselves. They're learning, as they go, just like everyone else. But we're working on, the next event. We're looking at doing two different events, one during the day and being more oriented towards the business community, a lunch and learn. And we want to have someone that has a background in addiction and in peer support come and talk. And we also want to include a component talking about the economic impact of opioids basically so people can realize, this is something we should do something about, and get people back, not abstinence-based, but get people back, back to normalcy, I guess, is one way of putting it. Treating it as a chronic disease, under that type of model, you can get someone, back into the workforce a lot sooner than if we just rely on abstinence-based treatment. And then, really what we're trying to build our panel around is around the concept of addiction as a long-term disease, and under the harm reduction, and that you can't get someone to treatment if they're dead, that idea. So we had a meeting about that yesterday, and we picked some. I think we're working on getting some good candidates.
Yeah, I wonder if it's coming up like we need to focus on including people and making it be an open conversation. I would really hope that's like you go out of your way to make that point when you're picking who to bring and stuff, because it's easy to overlook it, I think.
Well, I think what we need help with is getting that message out. So the most recent one that the city and the Call to Action group put together was a film screening at the Empire about a month and a half ago called The Anonymous People, which is exactly kind of what you're talking about. So it's kind of the play on words against, like Alcoholics Anonymous, like hiding and things like that. And it's bringing people out and talking about it and celebrating recovery as a goal and as something that we look for instead of hiding, right? So it was a great event. We actually changed our panel a little bit because of comments that we've heard like yours to be more celebratory, less about either punishment or even on the treatment side, and more about the recovery support side and how do we help people come up And it was a very moving event. They did a countdown of people in recovery, starting with 40 years, 30 years. It got down to somebody who was, I can't remember if you remember how, it was somewhere in the realm of like 2 weeks, right? And so, very recently in recovery, right? And the applause that was generated on something like that was absolutely moving, right? And that's the tone, right?
That's nice to hear.
That's what we want to work on. But downside of that, there are 150 people there. We probably spent, I don't know how much we spent on advertising, a lot of social media, a lot of things like that. You probably didn't have any clue what was going on, right?
No, I didn't know about that.
So we need help, right? Getting the word out on this in this day and age of instant gratification with notifications. We need help. We need a network that's following. We have an email list that you can go to the city's website, join that. We've got 300 people who signed up after the first event last May for call to action. We try to get it out to them, and everybody has their own networks, but 150 people to show up for this was a little bit unfortunate.
Yeah.
It should be. And this conversation today, right here, so I'm hoping we can replicate the whole thing, Facebook Live it, and replay it, because this conversation is absolutely what the community needs to hear. And there's so much good. We're so fortunate you're here, Michael. And we always love you, Frank. But this is what the community needs to hear, right? This is real experts, people who know what they're doing, people who've seen it, people who are bringing not just opinions to things, but really best practices, and bring that education. So we do have not just those technical solutions, which I think we have, but we have the political solutions, which means that people are behind it, so we can do things like medication-assisted treatment, and harm reductions, Narcan, things like that. So those are all political solutions that we need to do.
Our group has spoken in Frank's class. Frank's our faculty advisor for the UND Psychedelic Club, and we've gotten money from the university to drive to Fargo and speak about harm reduction. And it's not condemning or condoning drug use or anything. It's just the safety and education stuff like that. But there's a lot of students on campus, and Tuva and Nate can say, people come to our meetings and people who talk to us, like, as soon as they realize that there's something they can do or that they are invited to the conversation, they want to be a part of it. So if there's anything that our group or the students for Tristan's group, the Opioid Solutions group, if we can help you guys on any, like planning another event or doing something or helping you broadcast it or make a video about it or anything, a lot of people in our group, probably more people than we know, that would want to help.
Well, it's not an if, it's a how.
Yeah.
Right? You're invited.
Cool.
All right, well then.
You're included.
Yeah.
Everybody's included. This is, I had a quote way back in the Herald a long time ago. Herald is the newspaper for all of you young people under about when they say somebody, quote, when they say this is somebody ought to do something, everybody is somebody. Right? So this isn't one of those things where you say, well, somebody ought to do something. Right? In this case, that somebody is everyone. We're all somebody. So you're invited. Reach out. If you send emails, don't let us ignore you. Things like that, and just do something. We'll cover your back if you just go out and do something. All right.
Cool. Yeah.
When is the panel, the next one?
January 9th.
Still some decent
So
time.
on that note,
Sorry.
no, that's good, and that's our last question is usually what can we do to help, and in a case like this with addiction, I think the what can we do to help is how do we erase stigma, how do we get involved with advocating for funding, support, and treatment, and how do we change the conversation from one of abstinence to harm reduction. And I think those ideas are kind of already floating here, so I'm going to connect your groups via email so that you can share this information. And then this is clearly a conversation that needs to continue, and so we'll try to find other ways to continue this conversation in this community. I'm grateful that the city has taken it up and is taking it seriously, and I'm glad Pete's here to hear the feedback, and I appreciate all of you being here for this conversation. Thank you to Frank and to Michael. We give them a little round of applause.
So that was part 2 and last end of our recording from Kylie's Thirsty for Justice Thursday addiction seminar with Frank White and Michael Dulitz.
I had addressed it a little bit with my dad in the past episode about the stigma about harm reduction in general. You know, there's the whole just say no mentality, which has led us to this point. And it's really, really nice, really encouraging to see this, these people coming together and focusing on harm reduction.
Yeah, what do you think about listening to Frank in that context is kind of cool. So I've never taken Frank's class, so I haven't seen him do a lot of lecturing or anything. Was it similar to a typical Frank in class mode, or did he seem to have a different kind of tone or presence about his speaking?
Yeah, he so in his class was structured so that it covered a lot of drug information about drugs specifically, like pharmacologically and sociologically, how those drugs interact and stuff like that. But towards the end of his class, we got into harm reduction type of things, and that was really, the first harm reduction type of stuff I'd ever heard of. It, mostly I hear it echoed of just say no. Yeah, he did a great job talking about harm reduction and stuff like that.
I liked his wisdom teeth story, because I think we all have, or a lot of us have stories like that.
Sure, yeah.
My grandma, she gets medication, opioid pain medication, and she says she gets too much, and she tries to, she almost like begs the doctors not to give her as much as they do, and they always just do. And so, it's funny when they were talking about the take-back programs.
Yeah.
It's good that we have take-back programs, so people like my grandma or Frank, who's got too many of these pills, want to get rid of them and don't just want to throw them in the trash or keep them around their house. But isn't it kind of funny, that we need that? We can't just prescribe less.
Yeah, it's like pushed almost. It's kind of like pushed.
Yeah. So when Frank says, like, I like that story because he's got all this, he's read all this research and he's done looked at all the evidence about all these things. Great. But he also has bits of information like that. Like, I went to the dentist and they gave me too many pills. And we all have stories like that. Mm-hmm. So it's some real learning, a real life lesson that anybody can probably relate to somehow. And so that's why I also liked he was able to tell that story, because it kind of connected him with
sure, yeah,
people he's talking to.
Yeah, that was interesting. It was interesting they brought up Purdue and how initially Purdue suggested their research showed that less than 1% of opioid users, people that were prescribed opioids, less than 1% would become addicted. And that research was later found to be falsified and not really even research at all.
Yeah, from the beginning, as Michael explained, that source they were citing that shows that less than 1% of people become addicted to the prescription opioids was not a real study. It was some comment made on a scientific paper in a journal, and they were not being sincere when they were citing that as their evidence, and they knew that. And there's lots of news clips where they're saying this. They say the same thing over and over again. Less than 1% of people get addicted. Mm-hmm. And it all comes from this same source that they knew was bogus. And the communication of it, nobody challenged them or dug into that close enough, soon enough.
Yeah, that's interesting. Now there's here everyone has these personal stories of, having their wisdom teeth removed or whatever, being prescribed opioids just for a short amount of time. And then, my dad had mentioned that a large percentage of his patients, his Suboxone patients, start with a prescription like that. So that's just it's kind of interesting. I don't know. There's that disconnect, that disjuncture between, how a pharmaceutical company labels and represents their opioid medication versus how it actually, interacts with people.
I think what did Michael mention in this episode here? The cigarette tobacco lobby back in the day, lied in basically the same way that the Purdue pharmaceutical companies lied, but still, and I like how Michael said, the communication of the dangers of tobacco and our legal response to it, he thinks is one of our greatest public health victories in our history as society.
Yeah.
It seems great. But it's funny how the same people that lie about other things lie almost in the same way that the tobacco companies did. Mm-hmm. And it's all about evidence, yeah. So I'm so glad that he kept talking about
he brought that up many times.
Evidence-based support. And he said we need more experts and people who have real experience in all these areas to do the communicating with us. And, a focus on that seems like, obviously, the only way to avoid the sharks, the snakes, that would still sell cigarettes to you and lie to you, or still sell prescription opioids to you and lie to you about the risks. Like those people, I guess, are always going to exist, trying taking advantage of everyone else.
Mm-hmm.
So evidence seems to be the best way to combat that. And so I loved how they kept bringing that up.
Sure.
Evidence is what we need, because I think that's super reasonable.
Mm-hmm.
And North Dakotans, we're common sense kind of people. Like if you can explain to me how hard work is translating into, survival and profiting and flourishing, then it usually makes sense. And so we're people who don't do things without evidence, and yet some weird political things that hop into our thinking that seem to get in the way of that. But ultimately, we are reasonable people who don't do things without evidence. So I'm so glad that they're talking about that, embracing that as a virtue.
Yeah, that's great. They're coming at it with that whole harm reduction mentality.
And that all are welcome. We were talking about the intimidation factor. People at that community screening said, they claimed, there are no casual drug users. If you start using marijuana, say, you will end up addicted to hard drugs. So they claim there are no casual drug users. And then they say, even if they were there, we wouldn't listen to them because they're biased and as far as what drugs do for you. That seems really silly. And so I'm glad Michael also said that's not the attitude we're going to have.
Yes, a statement like that doesn't leave a lot of room for new discovery. It doesn't leave a lot of room for discussion and finding new ideas and stuff like that. So yeah, that's great that was brought up so many times.
So this has been the 4th episode of the Harm Reduction Report. I am happy you are here listening. You can catch the next episode, as always, Tuesday morning, 7 a.m., 88.3 KEQQ Grand Forks, or catch it on sandbaggernews.org or the UND Psychedelic Club Facebook page. Thank you very much. We're going to be talking about something else next week, so hope to see you there.
Thanks for tuning in.
Sandbag on.